why many patients are unable to lower the LDL cholesterol levels?
The best data, the most extensive data that we have is data from the Jupiter trial. And basically the Jupiter trial was conducted in a primary prevention context in patients with abdominal obesity and what we call the risk factor cluster of the metabolic syndrome. So they had a degree of insulin resistance. Now, Professor Ridker in Boston looked at the inter-individual variability in the cohort of several thousand patients. I can't remember the number. I think it was in excess of 5,000 patients in the Jupiter trial. He saw that 50%, slightly less than 50% of the patients had an LDL lowering response of 50% or greater. So the trial used 10 milligrams of rosuvastatin, for which we would predict a mean LDL reduction of between 50 and 60%. So more than 50% of the patients in Jupiter did not attain the mean LDL cholesterol reduction predicted for that dose of rosuvastatin. The most probable explanation is pharmacogenomic variability, that is to say, variability in the structure of the genes that code for the proteins in the membrane of the liver cell that capture the statin and take the statin into the liver cell where it reaches its target, which is the HMG chlororeductase enzyme. So there are data from Canada that show that in many patients, again of the order of 50%, the levels of statin in the blood plasma are much higher than they should be because they are not efficiently captured by the liver, and it is in these patients in which the statin escapes from the liver that there is a higher frequency of adverse effects, primarily statin-associated muscle symptoms. Now, what is important for the future is that there is a development in Canada to genotype patients for the key genes that determine the efficiency of capture of the statin and its entry into the liver. In other words, determine LDL lowering response to a statin. There is a choice of statins. Some statins are primarily absorbed through what we call a lipophilic mechanism. Others primarily are taken up through what we call the transporters with the genetic variation. So it is possible in the future that we will select statins individually on the basis of the genotype of individual patients. This is the future, and this is actually in process in Canada as an experimental approach to optimize, to personalize statin therapy and reduce the risk of adverse events.
Are we treating with low dose of statins?
Well, there are a number of surveys across European countries that suggest that the three statins that we recognize to be the most efficacious, so this is rosuvastatin, atorvastatin and pitavastatin. There are data from prescriptions from pharmacies that by far the highest proportion of prescriptions are for low-dose statins. And we believe that there is insufficient up-titration to a higher dose in patients at high or very high risk. Now, it is true that if you double the dose of a statin, you only obtain approximately 5 to 6% additional lowering of LDL cholesterol, and we know there is a small increase in the risk of adverse effects. So the difficulty we have is, what do we use in combination with the statin that will have a high benefit risk ratio? And so at the moment, following the Improve It trial, there is a wide suggestion that ezetimibe would be advantageous to add on top of a statin to attain an additional 20% or so of LDL reduction, which would be equivalent to 3 times doubling the statin dose. So in other words, we believe that adding ezetimibe on top of the statin would give us an additional approximately 20% benefit with a very good benefit risk ratio. Now, the other possibility, which is very new and reserved for very high-risk patients, is, of course, to add a PCSK9 inhibitor, but only in the patients at very highest risk, primarily because of the current cost of these medications.